today's session. She is a trained medical social worker with specialization in medical and psychiatry from Loyola College of Social Sciences. She has been working with Pallium India since 2020. She has been working in facilitating needs of pediatric palliative care wing under Government Medical College Trivandrum for us. She is also part of our home care services, giving advices in psychosocial care to the patients. Welcome, Gayathri. Over to you.
Thank you so much, Ms. Arathi. So good evening all. It's my pleasure to meet you all. So I think we have about 60 participants and now only 34 people have joined. So shall we wait for a few more minutes or? So yes, I think we can wait for a few more minutes. So today we are going to deal with the psychosocial aspects of care in palliative care. So I think that you are quite familiar with the concept of palliative care and the kind of work we are doing in Pallium India and all. So I think you are quite familiar with that. So when taking the concept of palliative care, it is very important to consider the concept of total pain, which covers not only the pain management or not only the physical aspects of patients, but it is giving due emphasis to the spiritual, the socio-economic, the psychological aspects of patient, not only the patient, but their family members too. So today, in the psychosocial aspects of care, we are going to see the objectives or the aim of psychosocial care in patients who are being suffering with any kind of life-limiting or life-threatening illness. So yes, as you know, palliative care, this is just a definition of palliative care, which we actually aims to improve the quality of life of a patient who is being suffering with any kind of life-threatening or chronic illnesses. So this is also meant to prevent and give some relief in their sufferings by means of early identification and thorough assessment and treatment of pain and other problems. So it actually covers the physical, psychosocial, and spiritual aspects. So along with that, what I would like to add is that I'm not interested to give you a complete lecture throughout. This is going to be an interactive session and you could add your inputs and you can also ask your doubts, everything. So please don't be very quiet. Okay, thank you. So this is a concept of total pain, which I have mentioned before, that it is a combination of the spiritual, psychological, emotional, social aspects of a patient and families. So when we consider palliative care, especially in case of Pallium India, we do not use the do not use the term bystander. So usually in hospitals, what we see is that they call the patient, I mean the person who is standing with the patient, we call them usually as bystanders. But in Pallium India, what we usually refer them as a caregiver. So like the patient, we also give due emphasis to the caregiver and the entire family. And social diagnosis is something which is something like a person in his environment, which means that when we consider a patient and their families, considering the social diagnosis, we usually see the psychological, the biological, the environmental factors of the patient and their families. That is usually known as person in his situation or person in environment. So we always have to look the kind of their environmental factors, the factors that contribute to their pain, or their psychological aspects, their spiritual aspects and all. So when a patient comes with a pain, like any kind of physical severe pain, what we usually do is that this severe pain might not be from their physical weakness. There are a lot of contributive factors like their financial burdens, their spiritual burdens, or their socioeconomic burdens would cause this pain. So what I would like to say is that a physical pain might not be always based on the physical weakness, but a lot of other contributive factors are also there, like the spiritual, socioeconomic, psychological pain would also be there. So when we consider a patient or when we consider a beneficiary, we have to cover all these aspects of their pain, like the mental, physical, their spiritual pain. So that is social diagnosis. I hope it's clear. So yes, as I mentioned, it is illness related suffering is it is not just a physical distress, but it is a combination of the physical, psychological, socio-economic, spiritual aspects. So in Pallium India, this is actually a multidisciplinary team where the doctors, the physiotherapists, the nurses, the palliative care assistants, the social workers, everybody contribute to the care and improving the quality of the patient and their families. So, when considering this multidisciplinary or this interdisciplinary team, the physical aspects would always be carried out or always be dealing by the doctors, the physiotherapists, or the nurses. And rest of the psychological, the socioeconomic, spiritual pains or their burdens would always be taken care by the social workers. So in Valium India, we have around 10 social workers and 5 community social workers, and this medical social workers are basically focusing on the welfare of the patients and their families. Whereas the community social workers are actually focusing on raising the volunteers from the community, advocacy, licensing activities, and all. So this is actually a combination of interdisciplinary team, including the medical and psychiatric social workers and the community social workers. So if you have any doubts, please ask. Next is why psychosocial care is important in palliative care. So, people with any kind of life limiting or life threatening illness would definitely have a lot of unique stressors or challenges. Like when a patient is affected with cancer or any other kind of chronic illness, and if he is from a poor background, like a below poverty line or something like that, or even if he belongs to a middle class or higher income class, he would definitely have a lot of traumas. I mean, a lot of dilemmas with him because he identified that I'm having cancer just 2 days before. So I have to do a lot of things. I have to take care of my family. I have to take care of my treatment expenses if I'm going for chemotherapy or radiation or whatever it is. So I have to take care of all these financial aspects. I have to take care of the education of my children, my job, so my elder parents. So all these would definitely be creating a lot of dilemmas for the patient when he realizes that he or she is having any kind of chronic illness. So at that time, when these people go through a lot of dilemmas or a lot of emotional distress, we can provide a psychosocial care for the patients and their families. Usually, in a general hospital setting, doctors or nurses would take care of the physical aspects of the patients only, and the rest of the psychosocial aspects uh, will be remaining unfulfilled. So what we are doing here in Pallium India is that, like the physical comfort, we are also providing a relief for the patients in all other aspects of the total pain, including the spiritual, including the spiritual, psychological aspects. So definitely, as we all know, that a serious illness disrupts the individual's entire thoughts, their cognitive aspects, their feelings, their relationship, social, spiritual support systems, etc. So we have witnessed a lot of patients who are suffering with any kind of illness would have severe marital relations or relationship issues with their children, their elder parents, etc., etc. So a lot of psychosocial issues would be present, and that is the time when we are intervening with the concept of psychosocial care. I hope it is clear. If you have anything, if you would like to add anything, you can kindly add in, or if you have any doubts, kindly unmute and ask. Okay, moving on. So before going to a psychosocial psychosocial care, the basic step of the care is assessment. So assessment is not only mere collection of a lot of data, a lot of information, but it is actually exploring the process of information about the person. So we are exploring a lot of information about the patient, including their relationship status, their dynamics of relationship, their socioeconomic background, their spiritual aspects. So a lot of things are included in the exploration of data. So an assessment should always be taken in a very wise manner, and we should not make the patient offended with our questions. So we should always ask them open-ended questions, and we should be good listeners when we are doing an assessment. So after assessment only, we can fix the goals and the plan. So in the planning part only, we can plan which kind of interventions would be taken for this particular patient. So what our goals should be maintained. So assessment is the basic of all the entire psychosocial care. So in an assessment, before collecting the data from the patients, what we have to do is that we have to build a very good rapport with the patients. So they should feel very comfortable. They should have the thought that this person is trustworthy, and I can tell whatever that comes in my mind, and he's not going to break the confidentiality. So um, we should bring such a thought in the mind of the patients. After that only he or she will disclose the very personal things about the patients. So we should be very confidential. We should have a very good rapport with the patients, and our communication should always be very polite, very humble, and these are the main things which we should keep in our mind before we going for an assessment. So this is aim of assessment. It is to identify the problem area which result from an illness, and that may influence the well-being of patients. As I mentioned just before, when a person is affected with any kind of life-limiting illness, they would definitely go through a unique stressors and challenges. They'll be going through a lot of emotional distress, or they'll be going through a lot of mental breakdowns and all. So the aim of assessment is to identify the problematic areas. So rather than focusing on the physical aspects, we should always explore the psychosocial aspects, including the social, spiritual, psychological, sexual health of the patients, and the aspects related to that. So what we are doing is that after assessment, we'll be fixing certain goals, certain interventions. So always the aim of assessment should be to identify the problematic area of the patients and the families. And assessment involves collecting information, identifying and honoring the strengths, resources, and needs. So in the assessment part, SWOT analysis is very important. SWOT analysis is WOT. SWOT is identifying the strength, weakness, opportunities, and threats of the patient. So identifying this will be very easier for the professional who is dealing the patients to identify the problematic areas, how the patient and the family is approaching that, and what are the kind of strengths and weakness that is existing for the patient. So it is very useful to analyze the patient's SWOT, strength, weakness, opportunities, and threats. So assessment this is just a definition on assessment, that it is an ongoing process as the psychosocial needs of patients and families or caregivers often change over the course of illness. So when a person or when a patient is coming to us, his initial goal or his initial need is different. And during the course of time, the needs of the patients will keep on differing. So maybe for the first time when the patient is coming to us, their goal might be like, I have to get some kind of physical relief. Like I have to get a comfort from pain. So my first goal would be pain reduction. But over the courses of time, when we are starting to analyze the psychosocial, or we are started to explore the psychosocial aspects of the patient, we'll gradually get into the realities of life, that this patient might be living alone, no caregiver support is there, or this patient do not have enough food to eat. At least he is unaffordable to have at least 3 meals per day, or this patient's children, due to his disease, they are drop out from schools or colleges. So over the course of treatment, the goals and the needs of the patient and the families might be changing. So in a psychosocial assessment, we need these two aspects: purposeful observation and purposeful conversation. So sometimes after 2 or 3 or 5 or 10 sessions, some patients would not disclose about their details, like they will not be interested to disclose anything about her. But we have to get the patient's background, like the psychosocial background, we need to get. But if the patient is not willing to disclose that, we have to use purposeful conversations to carve out the details. And purposeful observation is also very necessary. That is especially needed when we are visiting the patient's houses. So purposeful observation and purposeful conversation at times is essential in a psychosocial assessment. So how can we collect the information about the patients or the caregivers? So through collateral sources. Collateral sources is simply visiting the patient's relatives or neighbors or friends' houses. So all the time it is not possible to get enough data from the patient only. There are some patients, we have witnessed some patients in Pallium India, that they will not disclose anything about her. But we identified that they have some kind of psychosocial issues. So they are not at all interested in home care, or they are not at all interested in disclosing anything about them. So what we can do is that we can conduct collateral visits, like their friends' houses, their relatives' houses, neighbors' houses, etc. So the picture shown here is the houses. The first one is actually a way to one of the beneficiaries of Pallium India. He's actually a paraplegic patient. So it is a kind of steep hill, which is very difficult for the patient and the caregiver. His caregiver is a very old, around 80 years old mother of him. So it is very difficult for him to transport. So what we are doing is that if he wants to go to any hospitals, or if he Pallium India, or if we want to get an admission in Pallium India, we send ambulance, and along with that, 3 or 4 of our staff, including the ambulance driver and a man who supports him, would be there. So around six people would be carrying him from this steep heights and sending him to the hospital. So this is how many of our patients are living with very poor and very vulnerable psychosocial conditions. And the second one is actually house of a very old lady who was a cancer patient who was living alone. No caregiver support is there. So only through house visits we'll be able to collect more data. And collateral sources is also very helpful for many of our patients. So here is a case study. This is a story of a 56 years old lady who is Mrs. A, who has been diagnosed with CA breast in 2016, and she has undergone a breast removal surgery, and she was referred for pain management to Balinia. She looked very anxious and had no idea about palliative care in the beginning. So she is also she's also a person with comorbidities like diabetic since 12 years. She had CAD, coronary artery disease, heart-related issues, fracture on a leg, which was happened in 2019. So she is also a widow and having her children, but they are maintaining a very hostile relationship with this old mother. She is also living in a rented house. So this is the psychosocial condition and the physical aspects of the patient. So when considering the total pain, which we have seen just a few seconds before, what all things are the major concerns or what all things we have to address in this case? The floor is open for all, so you can include your suggestions. So when considering the concept of total pain, what all areas should be addressed in this particular case? Sir, could you please unmute and speak?
Dr. Hassan.
Hello, good afternoon, team. Thanks for the question. Okay, so Madam Lecturer is saying that which things to pick up in this. There are actually a couple of things we can pick up from this case scenario. You see that the slide you're seeing, the last line, she lives alone in a rented house, right? This number one. Number two is she is a widow and her children are having hostile relationship with her. So palliative care, as we have understood that 4 domains: physical, psychosocial, spiritual, physical, psychological, social, and spiritual. So it touches that if the person surrounding in me, in my family, I don't have good relation with them, and they are hostile to me, obviously I'll be challenged in having like is a loss of relationship, we can call it. And then social aspect, from the social aspect. And another thing is she doesn't have any idea about palliative care. These are the 3 things I think there's the most important challenges to manage her pain. Thanks.
Thank you, sir. Thank you so much. So you have covered almost all the points, and we have a lot of chats in the chat box like pain management, caregiver support, absolutely. So diabetic and CAD should be checked, and pain, loneliness. She's a widow. She's living in a rented house. Yes, absolutely. Then psychosocial problems, children's education, financial support. Yes. Loneliness is also a very valid point here, that she has been suffering from loneliness since nobody is there to take care of her. So that is a very valid point when we consider the psychological aspects of the patient. Then the economic aspects comes, the financial burden. No job is there, so nobody is there to pay the rent. So that is also a major concern. Then relating to loneliness and strained relationship with children, address financial, absolutely right. Diabetes and other comorbidities is also there, so we have to keep on check that. So yes, almost all the points are covered here. So I'm very happy that you have got the concept of total pain. So it is very clear for you now. Thank you. So yes, So when such a patient comes to us, when we are going to take a psychosocial assessment, these are the points which we usually taken care of. One is patient's overview. So patient's overview includes the personal details of the patient, like the age, then address, then the kind of what is her diagnosis and all. So that is the patient overview. Then coming to the insight. So insight is awareness on illness. So whether she is aware that she is a cancer patient, even though if she is having that awareness, is she clear about the consequences, the prognosis part, the treatment part, the plan, etc. Then if she is aware about palliative care, and if she is not aware about that, we have to provide the clear aspects about palliative care and the policies of Pallium India. And then we have to explain about that if she is not aware of palliative care. Along with that, we also have to take care of the caregivers' knowledge on palliative care too. We also have to give them due emphasis, and we have to ask them whether they are aware about palliative care. And if they are also not aware, we have to provide the same. Next is family overview. So these are the major steps which we follow in writing a psychosocial assessment. We usually call it as patient stories in Pallium India. So these are the major steps which we follow here. And family overview is that who is the primary caregiver of the patient? Does she have enough caregiver support or inadequate caregiver support? Or is she lives alone? So such things are to be covered in caregiver aspects. Then support system. If she is getting any kind of support from her extended family or any community support system is there. How is the relationship with the neighbors, the community resources? So such things should always be explored. Structure of the family is just like whether she lives in a joint family, extended family, nuclear family, or whatever it is. And the nature of relationship, she may or may not be having a straight. In this case of Mrs. A, you have seen that she is having a very hostile relationship with her children. So such things should be covered under the nature of relationship. And the final thing is genogram, which is also called as a family tree. Genogram is something where it is a pictorial representation of a family where we have to represent minimum of 3 generations and the relationship of each member with the family. And in that itself, we have some legends using here, which will be helpful to identify the kind of relationship, the kind of bonding between the patient and other family members. So that is genogram. So this is a very simple example of a genogram of this patient A, Mrs. A. So the first square shows square is male and circle is female. And you have seen an into mark in the square and the circle, which shows that the patients or the members, the male and the female, had expired. So they are no more. And I hope you can see they are husband and wife, and they have 2 children, Mr. B and Mrs. A. Mr. B is, you have seen an into mark there, that which means that he is expired, he is no more. His wife is Mrs. B. And this couple has got a child, Miss E. Miss E is married to Mr. E. He is a mason. And they have got a boy child who is 18 years old. Is it clear?
Yes, ma'am.
Okay, thank you. Then, as I said, this couple has got 2 children, Mr. B and Mrs. A. So we have mentioned Mrs. A in a circle because she is a female and she is married to Mr. A. Mr. A. So he is also passed away. He is no more. That's why we have put an into mark in that box. So we have shown Mrs. A with a good number of lines inside the circle, which means that Mrs. A is the patient. So 3 to 4 lines inside the inside the symbol shows that that is the patient. And Mrs. A and Mr. A has got two children, one male and one female. This male is Mr. C, who is a driver by occupation, and he is married to Mrs. C, who is a 33 years old lady, and they have got one girl child who is 11 years old. Then Mrs. A's another child is her daughter. She's a 32 years old lady, and he's married to a 35 years old Mr. D, who is also a mason, and they does not have children. So this is actually an example of a very simple genogram. So this is a simple example, but we we always used to draw a lot of complicated genograms where abortions would be there, twins would be there, strained relations would be there, father, sisters, husband, son would be included in the family. So these all people who are living in the same family should be circled like this. Mrs. A is living alone. That's why we have circled her in. We have circled her, Mrs. A. If Mrs. A and Mr. A is living together, we have to circle both Mr. A and Mrs. A. So who all are living under one roof should be mentioned with a bigger circle, which means that these many people are living in a single house. I hope it is clear. If you have any doubt, kindly ask. Yes, red lines. Then coming to the nature of the relationship, this red dotted line shows that Mrs. A and Mr. C is having a hostile relationship, very weak relationship. Also, that I have already mentioned in the case study that Mrs. A is maintaining a hostile relationship with her children. So these red line shows that the relationship between the mother and the children is weak. This plain line shows that Mrs. A is having a positive relation with Mrs. B. That is her brother's wife, sister-in-law. Is it clear?
Yes, ma'am.
Okay. Okay, moving on to the next slide. So these are the lines which shows the emotional relationship. So when we construct a genogram or a family tree, we should what to say? We should like we should draw the relationship, or we should address the kind of relationship with the patient and other family members. So the plane, this is a plane or a normal line. Second one is friendship or close with two dotted lines, double lines. Then intimacy or very close is like very thick lines. This is hostile or conflictual relationship. This is violence. Then comes the emotional abuse, sexual abuse, and neglect or abuse. So these are the kinds of lines which we usually use when mentioning the relationship or the bonding of the patient and other family members. The next one is ECOMAP. ECOMAP is actually coined by Anne Hartman. So it is actually a pictorial representation which helps a person to identify the kind of community resources existing in a particular community and the kind of relationship the patient.
Repeat the previous slide. Excuse me, ma'am. Please repeat the previous slide. Relationship slide, ma'am. Previous slide, please. Last two.
This one.
Thank you. This one. Yes, ma'am. This one.
Okay.
So do you have any doubts in that?
Hostile and confidential and violence, ma'am. These two, please repeat these. I missed these, ma'am. Please.
Okay, these lines shows hostile or conflicts. If any kind of conflicts is existing between the patient and other family members, we'll be representing that with these kind of lines. Violence is a little more steep lines. You can see the difference in the pictures, right? So it is a little more different from the conflicts. Whereas emotional abuse is almost the same of violence, but violence would always be drawn in red color itself. So we
Okay.
usually used to show violence in red itself.
Okay, thank you.
Emotional, sorry, doctor.
Thank you, ma'am. I got it. Thank you.
Okay.
Oh, thank you.
So shall I move to the next slide?
Ma'am. Yes,
Okay.
ma'am.
Okay. So the next thing is echo map, which is actually a pictorial representation of identifying the resources available in a particular community and the kind of relationship or the bonding the patient and the family is having with that particular community resources. So it is the kind of, say for an example, in communities, we'll be having a lot of support systems, including the schools, the health centers, the clubs, libraries, neighbors, and a lot of resources would be there in a community. So by constructing an eco map, we'll easily get an idea that what kind of community resources are available in that particular community and whether the patient or family is availing any kind of support from those resources. So here is an example of eco map. So the middle circle is the family unit, and these are the kind of community resources: volunteers, school, clubs, friends, religious institutions, community services, government services, workplace, neighbors. So everything other than the patient and family is a community resource, including the extended family, including the neighbors, including the schools, the educational institutions, religious institutions. Everything is covered under this community resources. So this is a simple example of an eco map. And when we consider the previous case of Mrs. A, this is a kind of support she is getting from the community. So she is having a normal, a plain relationship with the public health center. With the church, she is maintaining a good relation. But her relationship with the neighbors is a little weak. There is a very normal relationship with the panchayat system, the government system. Then she is having also a normal relationship with the palliative care. So one thing which we should keep in our mind is that when we take a psychosocial assessment of the patient, it is not at all possible to explore these many details in the first visit itself or in the first session itself. By conducting 3 or 5 or 7 sessions only, we'll be able to get a clear idea of the entire community resources, their family bonding and all. So in the first time, initially, we'll be able to collect their family details, her insights on the disease, socioeconomic background, etc. But some aspects like the eco map, then spiritual aspects, etc., can be covered after a lot of sessions. So it is not at all possible to carve out all the details in the initial session itself. The next step is socioeconomic overview. So it is very important when we consider a patient and their families that we should know, we should explore the details about the breadwinners of the family, the sources of income which is available for the family, if they are availing any kind of government schemes, including in Kerala, we are having a state government facility, a pension scheme for patients who are affected by cancer. And we also have disability certificates and disability pension. Then we have caregivers pensions here. If the patient is ill and he's a bedridden one, caregiver, the person who is taking care of the patient would be given a specific amount of pension. Then old age pensions are there. And also ration card is there. Ration card is here we have 4 kinds of ration cards. The most below poverty line card is yellow color, and just before that we have pink color ration card, then white color, blue color ration card, white color ration card. So from the public distribution systems, they'll be getting a certain amount of food kit, some grains and all. So we have to explore that, whether they are getting that provision. And if they are not availing that, we have to facilitate them to take the ration card, or we have to facilitate them to specific pensions. So the social worker or the person who is dealing with the patient and their family should have a clear idea about all these government schemes. Only then we'll be able to facilitate them to the necessary schemes. Then if they are having any other financial vulnerabilities or any debts or any other community support is there. So all these things should be taken in the socio-economic overview, and it is very important. Yes, CASP is there. Excellent point. CASP is there. Karunya Arogya Suraksha Padhati, and many of our patients are availed with CASP. So during the admission at the hospitals, they'll be getting, they wouldn't be paid. So they shouldn't pay the amount there. So during the time of hospitalization, they'll be getting it for free of cost. So yeah, CASP is a wonderful point. I forgot to add that. Then the psychological overview and spiritual overview. So in spiritual overview, what we are trying to do is that spiritual overview is not just about the religion which they are following, or not about only about their faith or their belief. CASP only in Andhra. We have CASP here. I think Karunya Arogya Suraksha Padhati, it is available in Kerala and it is a central government scheme, I guess. So it will be available in all the states.
Yeah, ma'am. This CASP is all over. The CASP is in Kerala. It is in the name of Nair Sursha Padhati, but all over India, it is in some other medical insurance scheme. It is available.
Yeah, I think it is RSBY.
Yeah, Rashtriya Bhima Yojana is there.
Yeah.
Rashtriya Swasthya Bhima Yojana.
Yeah,
That's
yeah.
RSBY.
RSBY.
That is
Yeah.
available all over India. It's available.
Okay, thank you. Thank you for that.
Thank you, ma'am.
So in spirituality, what we are trying to explore is the meaning and purpose of the patient's life. So they'll be having some kind of spiritual distress. So it takes some time to explore the spiritual overview of the patient. So in this, we can analyze the SWOT, like the strength, weakness, opportunities, and threats of the patient. We can also identify the joy and connection of their life, any particular person in their life to remember, or any memorable events in their life. So all such stuff would be covered in a spiritual overview, which is quite a tricky one, which needs a very in-depth skill to assess the spiritual overview of the patient. So it could not be covered in the first visit itself. After a lot of sessions only, we can go to the spiritual overview of the patient. Like that, psychological is also, many patients might be many of our patients are affected with kind of depression, low moods and all. So psychological overview is also very important in considering the total pain, or in considering the psychosocial care of the patients. So, considering the previous patient's case, that is Mrs. A, these are the concepts which should be addressed in the point of view of total pain. Physical is, we have physical pain, that particular patient has fatigue is there, she has lack of sleep. Since she had a fall in the year of 2019 and has got a fracture over her legs, it is quite difficult for her to work. Body image issues is there because she has removed her breast. So body image issues are there. And when considering the psychological aspect, she has isolation. She is lonely, has isolation. She's emotionally very weak, anxiety about the future, unclear about her prognosis and palliative care in the beginning. But later on, we have broken the bad news and we have educated her about her prognosis, and also we have provided information about palliative care and distress due to multiple illness because she has comorbidities. So these are the psychological aspects of the previous case, Mrs. A. Do you remember the case? Should I go back to that case study? Mrs. X, who is living alone, she is a breast cancer patient. She has comorbidities, had a fall in 2019. She lives in a rented house, having 2 children, both are married, but they are maintaining a very hostile relationship with the patient. And she does not have any other caregiver support system, have to pay rent every month, has no job, nobody is there to take care of her. So this was her case. So this total pain concept is actually about that particular case. So physical, psychological, then social, socio-economical, since she does not have any job, it is very difficult for her to pay the rent monthly. Then strained relationship with the family. She is unable to go for a job because of his comorbidities and other physical issues. House rent is a major threat for her. Low accessibility to hospital, absence of caregiver, that is also a major issue. When coming to the spiritual, she has low faith in God. There is no significant person in her life. No memorable events, no joyful events is there, and extreme spiritual distress. So why all these sufferings? Since I do not, I was a person who was not at all doing any harm to any of the, anybody, any humans, but still I am facing with a lot of sufferings. Why these many sufferings for me only? So such a question is there when considering her spiritual distress. So this is a concept of total pain. Then the kind of interventions which we can do here is that providing information. The basic thing which we can do is information providing, like she is unaware about her diagnosis. I mean, she knows a little about her diagnosis, but she is totally unaware about her prognosis, treatment plan. Yes, doctor.
Yes, Dr. Hassan.
Thank you very much. Sorry to interrupt. The previous slide, please. I have a discussion from you, ma'am. I will request the previous slide. Yes, in the total pain, physical, psychological, socio-economic, and spiritual. Okay. One thing is coming to my mind that no memorable / joyful events is life. Like there are some questions we usually ask the patients, like, are you still enjoying the same type of activities which you used to do before getting sick or getting with this cancer? So it correlates. So my question is, will it be still under spiritual domain, or it goes falls under psychological domain?
Yes, sir. It is actually a spiritual one, but it has a correlation with the psychological aspects too. So it can be in psychological and spiritual. So no significant person.
Very much.
Yeah, no significant person is there, no joyful events. It is a kind of spiritual distress too, but it can also be a psychological distress also.
Thank you very much.
Okay. So coming to the intervention part, so basic thing is, as I mentioned, it is providing information. So she is totally unaware about her prognosis, treatment plan, goals, etc. And also unaware about palliative care. So the basic thing which we can do is that providing maximum information about the setting and her disease condition. Then psychoeducation can be given, how to take care of herself, or how to manage her symptoms. Everything can be included in the psychoeducation. Since she has a kind of not depression, but it is a low mood, having strained relationship with others, isolation or loneliness is there, we can go for a supportive counseling. Follow-up should be there. Follow-up is not just when a patient registers in Pallium India or in a palliative care setting or wherever it is. From the time of registration, we should have a constant follow-up with the patient, like assessing her current condition, because this patient is living alone and there's no other support system is there for the family. So we should have a constant follow-up with the patient. Then bereavement support. Usually, this is not only for that patient, but usually we do bereavement supports in Pallium India. Rehabilitation supports is there, facilitation is there, advocacy, licensing, etc. is there. If they are unaware about the government schemes and all, we can help them facilitate. We can facilitate them to all the available schemes and other provisions for them. So these are the common interventions which we follow in Pallium India. And another, so I hope that till the intervention part, it is clear. If you have any doubts, kindly unmute and ask. Like assessing the patients is very essential, and it is documenting that is also very essential. So these are the major steps which we follow in Pallium India as part of our psychosocial care and assessment and the intervention plan. I mean, intervention part.
I'm sorry to trouble you. What is license, ma'am? I didn't get it, ma'am.
Okay. So it is about
Okay,
linking them with any. So sorry, Dr.
ma'am.
Hassan, please.
Can I please say this word, liaise? Are you trying to say to make a rapport or relationship or liaise with somebody, like to make relation with somebody with this word?
Yeah. Yes, absolutely right. It is actually like a kind of networking, like we are maintaining a relationship, a relation with the government system or any other community resource system, and we are helping the patient to link with them, like to the community system or the government system existing. Is it clear?
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
Okay. Common purpose, yes. Okay, then another important concept in palliative care is vulnerable population. So when considering Pallium India, we are actually following a list of vulnerable population. Like we always follow with them. We always like a constant follow-up is there with the vulnerable populations. So patients included in vulnerable population belongs to the Swanson criteria, like people who are living alone. Our previous case, Mrs. A, is living alone. So she is a vulnerable patient. Then elderly people living without any support, single parents, multiple patients in the family. We also have a good number of patients registered here who has multiple patients in one family itself. So those comes under vulnerable population. So what we are doing here is that we create a separate list of patients. We usually update that list. So here in Pallium India, we have home care services, and we have around 14 link centers, like 14 home care areas, where 3 to 4 link centers would be taken care by one social worker and one nurse in charge. So what we usually do is that for 3 months, we'll be creating separate, we'll be creating and updating the list of the vulnerable population in each of the home care areas. So patients who all are included in this particular groups has been considered as a vulnerable population. Then victims of gender issues, like if any kind of domestic violence, physical abuse, or sexual harassment, anything is there, he or she would be considered as a victim, like a vulnerable patient. Then individuals with mental health issues, with suicidal ideations, socially isolated patients, substance users in the family, individuals in extreme poverty, if they are even unable to meet the basic necessities, they would be considered in a vulnerable population list. And for vulnerable population, we'll be having a separate kind of intervention, and we'll be following up with them regularly than other patients. So this is vulnerable populations, which sees a quite important importance in palliative care. So these are the people who needs a kind of extra attention. So that's why they are considered as vulnerable, and we will be updating it by 3 months. Then next is caregiver. So caregiver is actually, as I already mentioned, caregivers are not somebody who are just bystanders. They are actually the invisible patients of palliative care or any other settings. So they'll be struggling with a lot of things, like the illness in the family, the financial burdens of the family, or the psychological distress, etc. So we always give, in any hospital, we always give emphasis to the patient only. But what we are doing here is that we give due emphasis to both the patient and the caregivers. That's why we are not at all using the word like bystander. Caregivers are also people who deserves who deserves importance, who deserves our respect and dignity. So respect those individuals and acknowledge their complex role. Then, so these are some of the happy pictures we have taken with the consent of the patient when they were admitted in our IP setting, inpatient unit. So, yes, next intervention of Parliament is about vocational rehabilitation. So, vocational rehabilitation is that if any patient, say for an example, if I am the patient or I am the beneficiary, if I met with any accident or if I have any life-limiting illness, and I was the only income source of my family, with this disease, the total financial stability of the family will get disrupted. So what we do is that by exploring more about the patient and the families and through psychosocial assessments, we will be provided them with a good number of vocational rehab supports like goat rearing, poultry farming, then install like textile business, binding, umbrella making, lotion making, stitching, tailoring, everything. So we, by assessing the needs and identifying the interest of the patient, we will be supported them with a good number of vocational rehabs. So this is one of the most important interventions which we are doing in Palim India. Then support for children. So when we consider our patients, majority of the patients who are registered in Palim India belongs to very poor socioeconomic background. So due to a multiple illness in the families or due to the illness of the primary breadwinner of the family, there are chances for the kids or the children in the family to drop out from their schools, and nobody is there to take care of them because the complete attention would definitely goes to the patient. So at that times, in order to avoid that dropouts and in order to improve the quality of the patient's family, like in order to enhance the education support of the patient's families, what we do is that we'll be providing like a scholarship, like for the patient's children or their grandchildren for 1 year. So we'll be providing a specific amount. So we have fixed some criteria. This year last year we have got around 500 students who are being supported from Palim India for their educational activities. So we have a specific criteria. We have standard operating procedures for that. And by considering those criteria only, we'll be providing amount for the students. So that is education support. And in education support, we have another program called mentorship program, where one thing which I missed is that the volunteer support which we have. So we have a very good volunteer support in Palim India, and many of these volunteers are supporting us in mentorship programs. Say for an example, one volunteer, one mentor is assigned with 5 to 6 number of students or mentees. So this mentor will be dealing with the mentees, and they'll be constantly contacting the children, as like assessing their spiritual or their emotional needs or whatever it is. So that is called mentorship program. So each student who belongs to 9 to 12 standard is having that mentor-mentee contact. I mean, have one mentor who will be supporting him or her in all the educational activities. So that is mentorship program. And we also have summer camps conducted for these students who are being supported for their educational activities. Oh, that is another part of the story. So things which we always have to remember is that we always have to evaluate our interventions. So whatever interventions we are being doing, we should always keep in mind that, or we should always check that whether this intervention brought any change to the family of the patient and their families. So we should ensure that the families always are benefited by the kind of interventions which we have provided. And assessments have to be revised and updated, and if needed, we have to reach out for help. And actually in psychosocial assessment, it is actually a kind of art and science which needs some techniques and skills to explore the details of the patients and families. And the main thing is that we have to intervene in the patient's life with positive, positive intervention. We have to provide positive interventions for the family. So that is all about the psychosocial care of the patients. And thank you.
Thank you, Gayathri. There are a few questions in the chat box that were, coming in from the start of the session itself. So I'll read out one by one. First one was, suppose a caregiver is not available, what kind of support can be given?
Yeah, very good question. So if a caregiver is not available, the first thing which we have to keep in mind is that we have to give due emphasis to the freedom and independence of the patient and the families. He or she has the right to know about their disease, has the right to take decisions on himself or herself. We are not people to take decisions for them. So if the patient is in a very vulnerable condition and we identify that she needs a caregiver support, then with the consent of the family, with the consent of the patient, if possible, we can link her to any of the care homes or shelter homes. If the patient is not in a condition to move from their environment, it is absolutely okay to keep them in that particular settlement itself, rather than taking out her from her setting or her background. So linking them to any of the shelter homes or care homes or Cheshire homes, it is absolutely good, but only by taking the consent of the patient. In some cases, there are very, very, very rare situations where the patient is completely bedridden, and if he or she is not interested to move from their house, it is also possible to appoint a paid caregiver. So we have one patient here in Pallium, India, which is a very vulnerable, a complicated case, who belongs to Karakulam Link Center. Karakulam is actually a suburb in Trivandrum district. So there we have one patient who is very vulnerable, and he is not in a condition to take care of himself. He has a sick father and a mentally retarded brother. So with the interventions of the government system, we have a lot of times we have gone to the social justice department, welfare department and all, and somehow we got a consent from the government to appoint a paid caregiver. So it is very rare case. If the patient is willing to move from their environment, it is absolutely okay to find a proper place for them in case of not having a proper caregiver support.
Next question. What are some psychosocial concerns? If you have any examples, you can give some examples of
psychosocial concerns. Could you please elaborate it? I didn't actually understand that. Psychosocial concerns?
Dinesh was the person who brought in this question. Are you there?
So generally we have a lot of psychosocial concerns here, like sustainability of vocational rehabilitation is actually a psychosocial concern for us. Like if we, I don't know, I'm sensible for that. I'm not actually clear about the psychosocial concern. We have a lot of psychosocial concerns here, like sustainability of a particular project. If a patient is linked to a particular vocational rehabilitation support, how long that can be sustained, or how long he or she can do that. It is actually a kind of, it's actually a concern for us. Is he or she would be able to continue it for a long time? Or would it really provide a stable income for the family? It is a kind of concern for us. Then patients, multiple illness in a family, it is actually a concern for us. Patients with depression is actually a psychosocial concern. So there are a lot of concerns when we take each and every patient. We have a lot of concerns.
Dr. Hassan, do you want to add something?
Thank you very much. Yes, certainly, ma'am. Like today, the presentation is really very much important in aspect of helping, not helping, doing something at least in the society for the cancer patients and other distressing symptom patients with other problems. And I would like to special thanks to the presenter today, Madam Gayathri P. Nair, to discuss so nicely, elaborately. So I just want to share with my fellow colleagues today here a small story. Okay, I work in a cancer clinic in Lesotho, Africa. So we see patients on daily basis, and one of the patient came with a 36-year-old male, HIV positive on ARVs, a very young patient, got married about I think 2 years back, and then this year diagnosed with a carcinoma of the penis. It was squamous cell carcinoma of the penis. So the patient, believe me, just after the diagnosis was disclosed to the family members, actually, he was staying with his wife in an individual house, and a low-income person, actually a day laborer, I can say. So just within a week, the wife left the husband. Okay, so okay, when we examined the patient, we found that the patient had obviously the lesion on the penis and epidermal skin, and also the like wounds on both inguinal regions, which were needed to be done dressing every day. So we prescribed a pain relief for the physical part. I prescribed morphine for the patient and explained to the patient about the drug and the adverse effect and how to manage it, and then give a checkup date for about 2 weeks to come. So when he came, he explained that his wife left him, and now his wound is more like extended and offensive smell. We could understand the team that it is not dressed every day. So what was the reason? We tried investigating the social welfare officer and the psychologist we called in our team. And then it was found that the patient was just taking the medication and was not going for dressing at the clinic. So yeah, so that those are one of the distressing stories. So I think a lot of huge psychosocial issues are associated with such type of distresses of the patient. Thank you very much.
Thank you so much, Dr. Hassan. It was more sensible than my answer. So thank you so much.
We have another question. What are the major or minor precautions that we should take while approaching the patient or assessing a patient? Also, what if a patient is hostile, and what if a patient is in altered sensorium?
So, so approaching a patient with any kind of psychosocial issues, or approaching a patient with any life-limiting or chronic illness, we have to be very cautious, and we always maintain a kind of decorum before approaching them. Like we should not make them very offended, or we should not ask closed-ended questions. Like our question should always be open, like, what are you feeling now? That is an open question. But rather than that, asking how, like, say for an example, do you have pain? So it is actually an yes or no question. So we should always include open-ended questions. And if a patient is not at all, if we find that the patient is not at all willing to answer our questions, give them enough time. Just collect their name, their patient overview, like their name, age, address, contact details. And if we find that they are very distressed, or they are not at all interested, or they are not in a condition to answer our questions, leave them, give them enough time, and say that, okay, next time when we meet, we can have a more interactive session or something like that. So we have to be very cautious before, like when we are dealing with the patients with who are in need of palliative care.
Next is how to convince the patient or family that the support being given is unconditional, whether they will have to pay for it in some way or other. Or in case of Pallium India, the services provided here are free of cost. but yeah, this comes as part of communication, because yeah, yesterday you might have no same answer, the answer that was for the previous question. Sorry, Dr. Hassan, are you? No. Okay, sorry. We have to approach a patient in a way that we don't be judgmental every time. So communication plays a major role while you approach a patient. So yesterday you have gone through a very elaborate session by Dr. Radha. So that itself is an answer to this question. So you need to be more approachable while communicating to the patient, and that's how this can be addressed.
And yeah, absolutely, Ardi ma'am. And I would like to add one more point to that. What the one thing is that Paliminja is actually running based on donations from various people, from various individuals, from various organizations and all. So we can make them aware that our function is like this. We are running on the basis of donations. So all this, if you are interested to pay or if you are interested to give some donations, it is okay. Or else there is no problem. We'll be treating every patient equally, and there will not be any partiality in treating the patients. If a patient is giving more donation, we'll be treating them with more quality. No, nothing like that. We'll be providing the same kind of support, I mean, same treatment, but we'll be communicating it with them that we are running on the basis of donation. So if you are interested to pay, you can. So your answer is quite sensible. Like it is already included in the communication, right? So it is fine. Thank you.
Okay, next question. Are there any situations where the full diagnosis is not shared with the patient?
Absolutely. We have a lot of patients who are not at all aware about their diagnosis completely. Partial knowledge would be there like I'm having cancer, but which stage, about the prognosis or the treatment plan, nothing would be known for them. So there are cases, and when the patient comes to us for registration, we'll ask the caregiver, is the patient is aware about his or her condition. So in the psychosocial assessment, we'll ask the patient and the caregiver, what do you know about your disease? What does your doctor told about this? So such questions will be asked so that we can identify whether they are aware about the condition or not. And if the caregiver says that my father or mother who is suffering with cancer, we are not interested to disclose their diagnosis with them, then also it is okay. It is absolutely okay. What we do is that we'll put a collusion positive in the facing sheet of the case sheet. So every professional or every team members who is dealing with the patient will get an idea that this patient is not aware about his diagnosis. So we should not give a sudden mental breakdown for them by disclosing the diagnosis. Yes, Dr. Hassan, please.
Thank you very much, ma'am. Just an addition to share with the colleagues' experience. I will not go to the story, but in one sentence, I think most of the cases among the people who does after the diagnosis of the life-threatening illness, some of them don't want to share with the relatives, with the mom or the husband, the wife or the children. The most reason here in Africa, like what I found in my clinic, that they have fear of losing relationship. That is the most common cause I have found when I'm talking to the patient. Sometimes I ask, and in the palliative care discussion, in the spikes, so they open up like this, the patients, that there is fear of losing relation. So please don't disclose like this. Thank you very much.
Thank you, sir. Thank you so much. So next is
next question is government help from different states for cancer patients, especially in Karnataka. We'll share the details separately with you, Dr. Mary. We need to collate some data on that, and we'll share it in the group or personally, whichever is yes.
Thank you, ma'am. Thank you, ma'am.
Yeah. How to address caste-related issues?
So, Dr. Surega, could you please explain it? Caste-related issues. Could you please share your thoughts on that?
Yes, ma'am. Good evening, ma'am.
Good evening.
Especially in suburban and rural places, the problem to deliver the care by the volunteer is limited by few of the barriers. One of it is a casteism. Like if the patient is of a higher caste, if the volunteer is of a lower caste of the same community, same living in the same neighborhood, they may not allow them to serve them. So any such issues have you faced, and like how to face it? Like already there is a scarcity of the volunteers.
Yeah, yeah. I haven't come across any of such situations. But one thing I remember is that last Saturday I have gone to a link center which is having a OP facility there in Palod, which is quite a rural area, which is around 60 kilometers from Trivandrum. So when we were conducting OP there, one of our patients' caregiver came there as proxy to collect medicines from us. So when
Okay.
assessing the psychosocial aspects of that patient, this caregiver is her daughter who is a widow. So what she was saying is that I was asking like, how is your community neighbor support? Are they very helpful? Are they very friendly with you and all? So I was asking a good number of questions related to that. Then suddenly this daughter disclosed that my mother is a very different nature. She belongs to a upper caste, which is a Nair caste, which is prevail in Kerala. So, and her neighbors belong to some lower caste. Some. She was mentioning a name, or I don't remember that. So she is having a like a kind of she's very much discomfort with dealing with that people, with her neighbors, because they all belong to lower than high her caste. So it is actually a issue. But she's an 80 years old lady. It is not at all possible for her, for us to educate her and to alter her thoughts. So it is not at all easy for us to do that. But she is comfortable with that situation and she's okay with that. And her daughter is seeking help from her neighbors also. So there is no problem in that. And till now I haven't come across any of the caste related issues. If volunteers, no, we didn't face such issues in Valium India actually. So I'm,
Okay, okay.
yeah.
Actually, when it is at a center, maybe like a proper center, maybe they will not even ask about the caste, everything. But when it's come to community, at the level of community, if you need to deliver the care, then these issues will prop up. So I really
We'll
had
definitely, yeah,
no
Dr.
idea
Surekha,
how to
we'll
address it.
definitely look into it. We'll see if we have any cases that our team members have, faced. Then we'll come with the solution for you. We'll
Okay,
definitely
thank
get
you
in
so
touch
much.
with you. Yeah.
Thank
Thank
you.
you. Next question is, what is the most challenging thing in your experience in psychosocial aspect?
So every case is a challenge for me. Every case, each and every case has some kind of challenges. So the most challenging case which I have faced in Parliament is dealing with the kids. So I was placed as a pediatric social worker when during my first time in Parliament India. When I was joined here, I was placed in Government Medical College. There is a special hospital called SAT, Sri Avittam Tirunal Hospital, which is exclusively for the mother and child. So I was placed there as the pediatric social worker for over 1.5 years. And the most challenging case I have been facing there is a little boy who has severe issue, who is 11 years old, who has severe conflicts with his stepfather. So they were living with the stepfather and his mother, biological mother. And this stepfather always teases him, doing a lot of harms to this boy. And this boy, who was very studious, suddenly dropped down. He got very less marks in exam, became more aggressive and all. So dealing with this patient, like this child and the father, was a very challenge. I still remember the kind of like how I was managing them was a really a challenge for me. So that is the most challenging case. But every case has its own challenges, its own pros and cons. So case is a challenge. But this is the one thing which I remember always, that it was very challenging. So we were going to a lot of government systems to get support for this child, to shift him to any of the care homes. So a lot of confusions and a lot of challenges were there. That is the one thing which I have faced. What if other question is
Something else. What if one patient is not willing to disclose the diagnosis to other parent? How to go about it? Sorry, what if one parent is not willing to disclose the diagnosis to other parent? How to go about it? Like, what was the question, Roxana Sheikh? Can you just elaborate what you are trying to ask?
is this the case for children or?
Hello, ma'am. Good evening. Hello. Hello.
Hello, ma'am. Hello.
Am I audible? Hello.
You're audible. You can carry on.
Yeah.
Yes,
So,
ma'am, you are audible.
Yes. I work in a pediatric setup in palliative care only. So my question is, I have one patient, like child is diagnosed with leukemia currently only. So the father know the diagnosis and he's not willing to tell the diagnosis to the mother. So like how to go about this? Like the mother has the right to know the diagnosis as well. So the question is basically on that.
So we can ask the father what all things that are that are not allowing him to disclose this to the mother. So first thing is that we have to explore that why he is not ready to disclose it with the mother. So is there any reason behind that?
No, the father told me he doesn't want the mother to get more of stress. So he's not willing to like
Oh, okay,
disclose the
okay.
diagnosis.
So what we can do here is that we can tell him we can have a interactive session with him and tell him that the mother should know, because she is the primary caregiver of the child. She might be the primary caregiver of the child. So in order to take care of the child in a better way, she should know about that. So we can convince him. Then also he is not at all ready to disclose. Then we can't do anything because it is up to their right. So we can't do anything on that. And before that, we can ask the mother also, do you want to know what your child is going through? What is the condition of the child? So we can explore the mother's perspective also. And we can try to convince the father in disclosing the thing to the mother.
Okay, ma'am. Thank you.
There is a question, is Talim India in Mumbai too or in Trivandrum? We have, Talim India is only in Trivandrum. In Mumbai, we do have centers for palliative care. So if you have any queries for patient care or any palliative care related activities that you want to know if there is there in Mumbai or not, we'll be happy to help you. Just get in touch with Sri Priya. We'll deal with it separately. Mr. Jacob Kurian. We can get in touch with you with a number of centers in Mumbai. Any other? I think we have covered almost all the questions in the chat box. Okay. Thank you, Gayathri, for this wonderful session, and hope everybody is Sorry, was I audible? I think it was muted. Okay, thank you, Gayathri, for all the the wonderful session that we had gone through right now. I think we have we were able to answer all the questions that you had. If you have any others, further questions, you can just give us your inputs through the WhatsApp group that we have. We can. So thank you so much. Over to you, Sinia.
Thank you, Gayathri, and thank you, Arnima, for being here with us today. And all the recording sessions will be shared with you in your WhatsApp and in your mail when all the sessions is over. Thank you all for being here today. Thank you. We'll see you on the next session. Bye.